Okay, you guys need to move a little bit closer, otherwise I don't know how you're going to see. You're also going to have to do so. At some point of time, you're going to have to put the books aside, okay? So, we are talking about the pulse dye laser. So, the pulse dye laser is this kind of model, comes in a gray shape. His name here in Haverford is called Herbert. However you name the one in Philly, it doesn't really matter. So somebody once named them Herbert. So he has an on button. There's the emergency switch off. The emergency switch off is very, very easily pressed. And the reason is if you ever see fire or anything unsafe, and fire would be really the only thing that would be unsafe, then you are allowed if you wanted to take your mask off. That's up to you entirely, right? And we're in a closed room without patient facing, okay? So here's our on button, and it takes about 7 minutes to power up this baby. This is one of the shorter powering up lasers. Some of the other ones by Candela take up to 30 minutes, so this one's about 7 minutes. Now, because he's warm, it's going to be much, much less, so he's already at temperature. He doesn't have to go through the warming cycle. I just wanted to show. If you hit that power out button, he will go out, and a power out button is really very important feature. Though I have never had to use one, but it is an important feature. If you accidentally hit this and you have to restart the laser, simply turn the key. It flips back to the normal 12 o'clock position and starts up again. And again, because it's warm, it's really not a problem. You'll be able to be back in operation in no time. When you start a laser in the morning, and it is not something like you're going to say, oh, but the medical assistants already started the lasers, we don't really have to do anything about it. But ultimately, we as laser operators are responsible for lasers. We have to understand that many things need to happen. Here's a cooling mechanism. And that cooling mechanism has water. It's distilled water that sits up here, and the level needs to be this one. Holly, do you see the level?
Yes.
Right, it really needs to be full. If you don't find it full, you need to replenish water. Where do you find the water?
Typically there's some in the room, but they're all, I see them in the back garage and also the other room with the shelves.
There is the storage room.
Yeah,
Okay, you guys need to move a little bit closer, otherwise I don't know how you're going to see. You're also going to have to do so. At some point of time, you're going to have to put the books aside, okay? So, we are talking about the pulse dye laser. So, the pulse dye laser is this kind of model, comes in a gray shape. His name here in Haverford is called Herbert. However you name the one in Philly, it doesn't really matter. So somebody once named them Herbert. So he has an on button. There's the emergency switch off. The emergency switch off is very, very easily pressed. And the reason is if you ever see fire or anything unsafe, and fire would be really the only thing that would be unsafe, then you are allowed if you wanted to take your mask off. That's up to you entirely, right? And we're in a closed room without patient facing, okay? So here's our on button, and it takes about 7 minutes to power up this baby. This is one of the shorter powering up lasers. Some of the other ones by Candela take up to 30 minutes, so this one's about 7 minutes. Now, because he's warm, it's going to be much, much less, so he's already at temperature. He doesn't have to go through the warming cycle. I just wanted to show. If you hit that power out button, he will go out, and a power out button is really very important feature. Though I have never had to use one, but it is an important feature. If you accidentally hit this and you have to restart the laser, simply turn the key. It flips back to the normal 12 o'clock position and starts up again. And again, because it's warm, it's really not a problem. You'll be able to be back in operation in no time. When you start a laser in the morning, and it is not something like you're going to say, oh, but the medical assistants already started the lasers, we don't really have to do anything about it. But ultimately, we as laser operators are responsible for lasers. We have to understand that many things need to happen. Here's a cooling mechanism. And that cooling mechanism has water. It's distilled water that sits up here, and the level needs to be this one. Holly, do you see the level?
Yes.
Right, it really needs to be full. If you don't find it full, you need to replenish water. Where do you find the water?
Typically there's some in the room, but they're all, I see them in the back garage and also the other room with the shelves.
There is the storage room. Okay, so once we replete the store that is under the sink here, and we normally try to keep a water bottle under the sink here with distilled water, right? Then if this is empty, go grab one and put a new one in so that the next person is not going to be looking for it. All right. So distilled water is what goes in here, and then the cap needs to be closed in order to be able to circulate. So now the laser is actually really at the temperature that it needs to be. It will always ask you perform delivery system test. This is not supposed to be a scary message. It's simply a message that it says, okay, I'm ready to start and let's do something with me. Okay, so who would like to press the check button? So this one has a little bit of a lag. You have to be a bit forceful. Very good. All right. So here on this screen you see many different parameters. And what these different parameters will do for you is you need to, do you want to put the chair out of the... What these parameters do for you is they actually provide you the ability to treat your patients. So this particular fiber is fitted out with the ability to give you many different spot sizes. And you see on the bottom screen there is a 3 by 10 millimeter, 3 millimeter, 5 millimeter, 7 millimeter, 10 millimeter, which is highlighted because that's currently the one that is attached, and then a 12 millimeter. There are also two others that are called 7 PL and 10 PL. PL stands for pulsed light, and that's pulsed light and no laser. So in other words, you can put a window, a screen in front, and actually just use it as a regular IPL. However, it's an IPL that will only deliver that wavelength, and that's the wavelength 595 nanometer. And those distance gauges, they are silver in color, and what they have is a screen. When you touch it, there's glass. Right? So there's a glass, the laser hits that glass from the inside coming through here. And one is a 10 millimeter and the other one is a 7 millimeter, which corresponds to your PLs. And you use, exactly, it can be put in 190 degrees. And why is that? Sometimes you're at an angle where it's not opportune that you actually have that piece, that rail, your spacer in that area. And then you can simply turn it around, not while it's in operation, but in standby, and then recalibrate. And then you can treat and see better. And this is the reason that it is made this way, right? So you might have a preference of how you put it in. Like I always put in my distance gauge this way. Why? Not really so sure. It's kind of a habit, right? But maybe, again, every once in a while I might turn it around. All right, let's talk a little bit about distance gauges. Distance gauges are super important for a laser, right? They give you the size of what you're trying to deliver. And that has something to do with the lesion. It has also something to do with the energy and where you want to hit in the skin and how deep you want to go. Because the higher the energy level, the greater the penetration into the skin. And sometimes when you have a very high energy level and a very high opening, a very large diameter distance gauge, you're going to be causing a lot of havoc. And so there's a natural inhibition of this laser it will not allow you to go haywire and kill somebody with it and creating a large hole. But those distance gauges have multiple windows. The external windows are the ones that we can replace, and these are here and here. Most important, before you bring any laser into operation, is actually to check that your windows are clean. So you have to actually remove that distance gauge, take it out, look against the light, and see what's hanging out there. Look against the lamp, it's going to be easier. What do you see?
Dirt.
Specks, yes. Right? Okay. Now, do these specks look like regular dirt, or do they look maybe like they're in that glass?
A few are on it and some are in it, and yeah.
Okay.
So I see.
So what happens over time and it can be any of the four windows. So there are the windows outside, and then there are smaller windows inside that we can actually not replace. But what happens over time, if you allow that laser energy to go through, it will etch the glass at some point of time. So what you have to always assure is that your outer windows are clean. And so let's learn how to clean the windows. All right. So we go typically over a surface where we can catch things, and then we're going to take out the rubber bands of both sides, and then we're going to clean the windows with a microfiber cloth. Alcohol is a great fixative. Alcohol is not good for cleaning. So if you want to fixate something, like if you want to put that dirt there, put the alcohol on. But So if you really want to remove it, microfiber is the best. Do you guys know how to take the windows out? Okay, Holly, your turn. You want to be over this surface so that your lens is not moving away.
She had a little tool that, or Channing had one that.
She has a tool? I don't
it
have
was
a
a little
tool.
tiny.
Okay, I'm going to show you how I do it.
She had a little. Just pop that out. Oh,
I do it just like this.
just for the nail.
Yeah, I mean, like, I used to use a pen. You know, there was always a pen in my pocket. But I don't use a pen anymore. That always creates these little purple marks there, and I hate them. Right? But it's okay, even if you had a purple mark. So whatever you find, but it is easy with a fingernail. So I need you guys, I'm going to put the lens back in, and I'm going to need everybody to try that. You can use a pen if you want to. Where's my next lens? But I just need to make sure that you guys understand and can do it. So that your inner window is a little on the cleaner side, so you can go in, cleanse a little bit. You don't want to have dust specks on there, so you have to be fairly fast to kind of then close the area up. Then you want to wipe as much as you can. And of course there are going to be, again, over time, some edges that are not going to move out because the laser is fully going through these windows and will be damaging even the glass, those lenses over time.
And this is why they are there actually. So they damage these lenses and not the internal lenses and not the inside.
Somebody
lenses.
cleans this one, please. And then I'm just going to hand it to you, and then you don't want to touch it with your fingers at all after you cleansed it. You can only touch it sideways. And then just hold this and then put it back in. And then you see there's almost like a squarish side to it. Doesn't matter where that lands because the rubber band is sealing it off anyway. Okay? Very good. Okay, now you can attach it back to the laser. Alright. And again, at that moment, really important not even to touch that window anymore, right? Good. There is an additional feature, other than that we now know how to change the tips. There's an additional feature in the laser that can sometimes reduce the energy level that's coming out. Now, I know I'm going into troubleshooting right now, but the whole purpose of this is that you know at all times why your laser is not calibrating, for example. So the laser has an additional window, an additional filter that is not one that ordinarily you do anything with. But if your laser is not going to be able to calibrate, and it says there's a fault called 15.1, fiber transmission is low, then you have to know that you have to clean also that lens. So let's find that lens. It's actually in the handpiece itself, so we're going to take the distance gauge out. And then this window sits in here. It's a small disc. And there's a magnet that sits in here next to the distance gauges, and it always needs to be there. And this magnet has an out button, side, and an inside. So with the outside, you can actually take this lens out. Now this lens, if you look through, you can hold, either one of you hold it, look through it. It looks pretty etched, right? There are lots of little small scratches. At some point of time, after a number of years, it might be such that it needs to be replaced.
Years? Usually it's a few months.
Okay, that depends on the users. After a few months, it has to be replaced, or what we do, sometimes we become very desperate. We're in the middle of a treatment, it's not moving anywhere, we take it out. We remove that extra so that it does not stop the laser energy from to calibrate the laser. But we can put it back in at this point of time. The laser has just gone through a preventative maintenance treatment, and so the laser is in full operation. So in order to put it in, there's only one way of getting it in, and I always forget which way it is and where the buttons need to be, because they're two. You see, it looks a little different on both sides. One is indented and one is flush, and I always forget. So I try. If it works, it's good. It did work. If not, I turn it around. Right? So don't be frazzled if it doesn't go in. Just turn it over and it will do.
So it will always tell you when you need to do that.
There's no screen that says take that filter out. It says fiber
what you
transmission
said,
low,
yeah.
right? And that means your laser is not, that fiber is not reaching in that calibration port which sits in here. That fiber is not transmitting into the port that reads things. Alright, so we're back with our window. Now that we've gone through how to operate the mechanics of the laser, now we can worry about what we really want to treat and what we want to do. So we were already at the screen. Now we changed from 10 to 7 millimeter, and you see it's now highlighted here. I know it's not very highlighted, but at least it's something that is super important. Now technically, before you put any laser into operation, before you hit the button to turn it on, obviously you need safety glasses. The safety glasses need to be for the laser that you're operating. It cannot be, oh, let me go over to the Alexandrite room and borrow one from there. That's, here's a bystander, let's give them the glasses from somebody else. If you have a bystander, you don't have functional goggles for them, send them out. There's no need for somebody to get hurt from a laser. A laser bounces through all sorts of things. We don't have any reflective surfaces in here. We don't have mirrors or any windows where a laser beam can bounce off, but it can still, you might be casually kind of doing something and then all of a sudden it goes to the bystander and meanwhile you've damaged their retina, right? So really very important to understand that the target of this laser is mostly vascular, mostly red, but if you want, you can also make it work against brown because they're on that same curve and that same coefficient of absorption. The most important is what you want to treat, and that actually tells you how you need to work the screen. Is it going to be a singular blood vessel? Is it going to be a cluster of fine little things that are not isolated blood vessels? And so here you need to have a little bit of an appreciation of the anatomy of what you want to treat. Let's say you have rosacea. Let's say you have somebody with isolated telangiectasias all over and then this background redness. There are settings that are going to be more conducive to wanting to narrow those blood vessels, and you might want to actually create an intense bruise in them. And then there are other scenarios where you want to use the slow cooking technique to kind of just get somewhere. And it is not entirely just straightforward. You have to understand a little bit about where you want to be. But let's take the most dramatic example of a port wine stain. A port wine stain are clusters and clusters and clusters and layers of blood vessels. And although you don't see them, you see that intense redness, but there are all of these blood vessels underneath. What you need to do in order to make any impact is actually go full force. And the fullest force that you can do is large spot size, lots of energy or as much energy as you can put in, and an extremely very small pulse duration. That means all of that energy that you want to deliver, let's say on a 7 millimeter spot size, the laser will allow you to go all the way up here to 8 to 19. That's the highest that you can go. I have never operated the 7 millimeter at 19, but that's a whole different story. But if you want to go that full force into that depth and deliver all of that energy over that miniature period of time, you're going to be causing a bruise because the blood vessels are going to be leaking immediately through the impact of the heat. The blood spills out and here's your bruise. And of course you're going to warn the patient beforehand. And why does it make sense to do so? Because you really want to destroy those blood vessels. You don't want to leave them alone. You don't want to pamper them. You will not go anywhere if you're doing just a little bit of a, something. So you need to use that full force, but most of the time we will be using a 10 millimeter spot size for that. And there are some scenarios where most of the time our algorithm, at least starting on the face, will say you're probably anywhere going to be between 5 and 7 millimeters. And why is there a range between that? Because when you first hit the skin and it shows you what it does actually show you with a little bit of a delay, then you sometimes don't know what the laser is capable of. Now this one was just calibrated, right? The preventative maintenance took place. It might have a higher output than, let's say, 3 months down the road. So it's really, really important that you do your first spot and now take a deep breath. Then look again after about a half minute or a minute. And when you look again, you're going to see how purple an area is. And once you know how purple that area is, you can then say, okay, well, maybe I want it a little bit more. I need that super eggplant color. It's not there yet. Let me up a little bit. And you can go maybe 0.5 joules up. See again. And then at some point of time, you arrive at the settings. Sometimes it happens, you do the first spot and you say, oops. Of course you don't say it because that's not good, professionally speaking, but you're going to say, let me calibrate. I think I don't even need that much, right? And so then you're going to go down a little bit. So algorithms are guidelines, but they're never set in stone. We always, in laser medicine, have to look for our endpoint, our tissue goal. If you see something that you're not expecting, you're not even close to what you want to be, right? So really, really important to have this appreciation that whatever you do, still think. Don't just blindly do. All right, so let's going to move forward. If you were to create a greater pulse duration, because you don't want all of that crunch at once, and that is something that we want to do in keloids, for example. We don't want to deliver that crunch at once. We go to settings that are allowing that energy to disperse over longer periods of time. And so, we have the ability to treat at 6 milliseconds. There are rosacea settings that we use where there's a combination of very visible blood vessels and that background erythema that's just sort of diffuse, and we use actually 20 milliseconds. I'll get to that in a second. I'm sure you've seen those settings. And then there are even those leg veins that we treat at 40 milliseconds, and the veins that we have on the sides of the nose that we treat with 40 milliseconds, and most of the time with this linear distance gauge that has a 3 by 10 millimeter spot size. Okay? So overall, this is sort of where you want to be. The energy is oftentimes in that algorithm. So the most important is choosing the size that you want to treat with. And sometimes that's dependent on the actual spot, and then sometimes it's dependent on how much energy you want to deliver. I'm going to show you how. Now you see you can go all the way to 19 with the 7 millimeter, but if I insert the 3 millimeter size, what I can do is I can create a very, very different and much deeper. You see it only starts at 21, and then you can go all the way, 40, right? It actually says right here, you can go all the way to 40, and that's a very, very deep tissue penetration. Many times you don't need that, but that's a possibility. Because the spot size is so small, the laser now allows you to go that route. Because even if you were to beam all the way through, most likely you're not going to be causing a catastrophic heat injury. But with a 10 millimeter spot size, you will not be able to go to 40 because you're going to burn a hole, right? And burning holes is not a good idea. So, okay. So as you just saw, every time that I'm changing the distance gauge, it's going to ask you again, are you ready to proceed or something like that? No, that's not what it says. But it says something about verification, right? And then you just hit the go button. So let's say we want to treat a few things. I told you about algorithms that we have, but the laser has its own algorithms. And where are those? Okay. Yes, in applications. Now it gives you a whole menu, right? How nice. Somebody actually thought for you. Now, when the precursor model of this was only available, at a 0.45 millimeter second spot size, we didn't have all of this. But then, with some kind of finagling, somebody thought, okay, well, let's give some guidelines, right? And there are, in fact, really nice guidelines. So if you are ever completely like, what did I do? I don't know where my access to whatever is. Like, you don't find the Channing brochure, though it's on the Z drive, and you're supposed to actually learn those settings or have at least that catalog in front of you if you haven't treated something, you want to go back and refer to it. But let's go to port wine stains, right? So it gives you a little bit of an idea of what you can do. It will say here, if you have a facial port wine stain, you should be choosing the size 5 to 7, right? If you have one on the neck and head, maybe you go with 7 or 10. So with the facial one, between 5 and 7, you can go deeper in the energy. The face can somehow absorb that. Trunk and extremities, you can actually dial the whole range. And then there's still hypertrophic port wine stains. There's not much of a change, it's the same. But let's say if you go to a port wine stain, you have one on the trunk and extremities, and you click here. Now you already parked your 10 millimeter spot size. Not only will it give you that suggestion, but it gives you a range. You see, it's from 5 to 7, right? So wherever you are in this range, right, you are in what is the recommended zone of this particular spot size for this particular clinical application. But they give you a range because the tissue endpoint might be different amongst and it varies depending on how much of an output this laser has at a given time. And then let's say if you wanted to go back to the let's say the hypertrophic one, sorry. So you're still going to go back and see how much it changes. Now what happened here? They didn't know. They are challenging to treat. So there's no guideline, right? So not particularly useful to use for something. And that comes the way it comes into play, where you're going to ask me, what should I do next, right? I have somebody with a hypertrophic port wine stain. These are the ones with that facial port wine stain. They have the little knobs on top. Have you seen any of those?
Not here, but just
In general.
In general, yes.
Right, exactly. So, those thickened areas really, really very challenging to treat. And it would be better if patients were treated already in infancy. They might probably not have gotten to having hypertrophic port wine stains. So the earlier we can start port wine stains, the better. That's just a clinical, part that you need to know. So here, it really doesn't give you anything. And so it's an application without use. They thought at some point of time somebody might come with some ideas, right? But they haven't yet.
Wait for you.
I was just about to be waiting on you.
Okay. So, but you see, there are many other things that we can treat, right? You have angiomas, and there are cherry angiomas, spider angiomas, and hemangiomas, right? We are treating hemangiomas of infancy, right? Babies that have actual hemangiomas. There are cherry angiomas. These are the flat red dots in the skin. Does anybody have a cherry angioma to
so
show?
many. We know where to start.
Okay, here is one, right?
Yeah, there's
so
one.
cherry
Camera
angioma.
on me.
It is in flat and in skin level. And that kind of cherry angioma is actually a coil of blood vessels. So, although they're all kind of clustered together, so we want to go with a short impact to make it purple, and that makes it go away in one treatment. It doesn't go away on the spot. It takes approximately 10 days until you no longer see that cherry angioma. So you also need to always educate your patients on expectations, because they're going to be calling you the next day. No, they're going to be texting right into your cell phone. They're going to say, it's not gone. Why did I just pay your money, right? Yeah, oh, forgot to tell you that it takes 10 days, right? And say it up front, patient will not call. If you say it takes 3 weeks, don't even call me beforehand. They're going to say, Holly, it went away after 10 days, right? They're going to be ecstatic, right? So it's all about knowledge and what happens when you do something vascular. So you have a whole category of how you can treat. So if you have a hemangioma, I'm not trying to say that you're going to be treating infants. If you had a baby with a hemangioma and that's bleeding and you need to somehow stop it, it will give you now this range again of what you can do. And these are very conservative settings, because these hemangiomas are oftentimes in babies. And so that laser company made sure that whoever's operating is not all of a sudden thinking, oh, let's go with a 7 millimeter on a baby's head. That doesn't work. It fries, and it's really, really bad. So they put some safe guidelines in here. And they all make sense. But the safe guidelines are, after all, safe guidelines, and many times they fit with the clinical and the experience that we have all gathered since the many years that vascular lasers have been available. And sometimes they are a little bit more conservative than what it needs to be. But you see, there are a number of different things that can actually be treated according to this menu here, right? You have like a whole slew of telangiectasias. You can maybe treat some matting on the legs that has been created after sclerotherapy to some spider veins. You have regular leg spider veins where you can do something. You have rosacea. You have these nasal telangiectasias. You have facial telangiectasias. Then you can do something for photo rejuvenation. And here your PL handpieces come in with the pigmented lesions where you're blanching out the red by pressing on, and you're going to be treating the brown only, right? Really nice and really neat. And then you have angiomas, and we just went through that list. Port wine stains, a number of different settings. Warts you can treat. I don't know if you're going to be treating warts. Maybe, Kate, you will be treating warts. I treat warts a lot with the pulse dye laser. And so there are some kind of guidelines, some settings. And then there's a miscellaneous of all sorts of things. Like, we treat striae with this pulse dye laser when they are red, not when they're white. Then we use the 1540 nanometer laser. There are certain types of scars when they are red that we want to reduce the color. Poikiloderma of Sivat, that is that discoloration on the sides of the neck, that is mostly red. Inflammatory acne, we actually treat with that. What we don't treat with this anymore is a venous lake. That is really outdated. You can't really make a venous lake go away. That's a bluish macule on the lower lip most of the time. You can't really make that go away with a pulse dye laser. You're going to be lasering forever.
What if someone had developed Tyndall after as a filler, either under their eyes or their lips? Would that, even though it's not a venous lake, would you ever treat?
So this laser can only see hemoglobin, but the Tyndall effect is because you have a liquid phase that is between the dermis and the fat layer. And unfortunately, there's no hemoglobin there. And because you have no hemoglobin, the pulse dye laser will not be doing anything. If you can penetrate that and make that liquid layer not as liquidish anymore, for example with a picosecond laser, you can probably achieve some difference. I've had a patient who home injected Sculptra under her eyes. She had blue everywhere and home injected. There are now Sculptra topical like pens available that you buy online, and she had this blue color throughout, and so eventually after about 4 picosecond laser treatments it actually moved away. So it was just perforating through that liquid layer in order to actually move that away. Not because the picosecond saw the blue. That blue is just a reflection that we see. It's not blue actually, right? And so, but it was the pico energy, that high intensity skinny beam that goes through, right? So, there are venous lakes are treated with a YAG laser. There are settings that will make that venous lake go away in 1 or 2 treatments. Nobody uses the pulse dye. If anybody still uses it, it's a disservice to a patient. Okay? And psoriasis, you can actually treat an inflammatory condition, just like acne. You can also treat psoriasis, and then whatever benign vascular gyn lesions, because they also want to sell that to gynecologists, right? So you have all sorts of different things, and then we treat more. We also treat basal cell cancers with this baby, and there are some treatment guidelines for that. And does it always work? I think there are certain locations in which it really doesn't work, and that's the side of the nose. Really not a great idea, but there are many other locations where it works wonderfully, and where you don't really need to induce a scar and take out something with a surgical knife, but where you can go without additional destruction of tissue, and that's really beautiful. All right, so when we are thinking about operating this laser, and we're going to do like now a demonstration of the operating. Can you spare that cherry angioma on your abdomen?
Yeah, totally.
Okay, all right, so then let's go back to, first of all, setting before we even put the goggles on.
Yes.
Yeah? No, I was just checking that somebody was actually in there.
Sorry.
Oh, good. So when we're thinking about taking a cherry angioma out, we're thinking that small guy, he deserves a tiny spot size. Well, we're gonna do. You have a few also. We can practice on all of them.
She wants first.
What we do is we want to go as small as possible, but with a little bit outside, so that kind of go through. And that actually is true for all angiomas, spider angiomas, the smaller heme angiomas, all of those where we want to create that. So what we do, we're going to go with a 3mm spot size. Okay, somebody take us here. You can treat both first, maybe, if you want to, and then we'll
I think I had a big one, but it's gone.
Okay, well, we're going to get to that in a second. Let's focus a little bit on the laser itself. All right, and what did you want to do before you put that one in, Kate?
Oh, I should have checked to see if it was in.
That's right. Nope, the other way. You can only look in one direction because if the other direction is not going to let you penetrate, like your eyesight is not going to be as
Pretty
great.
good.
Pretty good?
Agree.
Okay, so there's always a possibility. I mean, so it's very good because it's really used. So I always do that. It's kind of anal. You know, I just always cleanse even the top so that I have no schmutz on anything. Then you can insert it. Okay, and then you need to know the smallest amount of energy that will create the purple is the right amount. What is the smallest amount that will create that energy?
So I know it's like 1.5 milliseconds.
That's a good start in terms of
Sometimes it's
milliseconds. So
0.45.
you can, if you feel like you're not getting anywhere with where you started, and you feel like you need to create some more juice, then you can shrink your spot size to your energy delivery time to 0.45. Now, I like this one, but not everybody needs 18. And since Baruch has a few, we can now practice to increase the energy settings to see what we really need. Okay, so let's start even a little bit lower. What I want to show you, what I really want to demonstrate is that the lowest energy that creates something is something that we don't always have in an algorithm, right? And if you have only one to treat, sometimes it's difficult. But you want to have an understanding of what you're actually doing. Okay, so Baruch, can you up with the shirt? Yes, in just a second. But let's identify which ones. Can we draw on you? Is purple marker okay? It will come off only after 4 days. Okay, 1 second.
Many, huh?
On there.
It's bigger here.
Yeah, we don't need bigger. We just need. Don't move for a moment. Just keep as is. Okay, and what do we have?
Yeah, I know. I'm like, I know I have.
Okay, I think we have enough to play with. All right, so now we need everybody goggled. Okay, how are we going to do this one? That is really difficult here. This one. Because we broke so many of our glasses. So you still have one of those goggles in your room that recently was also sacrificed. Can you please wear these instead
I
of...
cannot take how I'm going to operate.
What do you mean operate? We don't need
Camera.
to see. But it's not important to show the camera right now. You can turn it off. This is an access level. How do we calibrate the laser?
This button.
Okay. And what does he say then when you press it? What does it say?
It tells you the settings that you're on.
Okay, repeat all of the settings.
14 joules, 1.5 millisecond, 3 millimeter spot size.
Okay. Are you content with those?
Yes.
Is this really what you wanted?
Yes.
Very good. So now you can, sorry, it kind of times out. And once this window comes back, you just confirm it. What does it say now?
Press finger switch.
Press finger switch. Finger switch is the finger that you see. Now he's calibrated.
Cool.
Okay, now you can, obviously right when you have this window, you can actually remove the gauge and you're in that operation. If you now talk to your patients for, another few minutes, your alcohol, you didn't get everything done beforehand, and you leave this thing in there, he will go back into standby mode. That's an automatic feature. Don't be frazzled. Let's say if that were to happen, let me just take that distance gauge. Once you've already taken it out, it doesn't happen. But if you leave it in and you talk for a little while, it goes back into that mode. You don't have to recalibrate him. Automatically, when you toggle here, he goes back into that ready mode. If you feel that you're going to be talking to your patients for a couple of seconds, let's say if you forgot to prepare the skin and it's happening, and you've just calibrated and you don't want to go through calibration again, just take it out for a second, put it back in, address your patient, and then it stays in that calibrated setting. That's kind of my little shortcut. Okay, now you can remove it. Okay, well, can you pull up your shirt, please? Okay, now it has a finger switch. We could also attach a foot switch for the treatment, but this one has a finger switch. So pick any of them, maybe, top one first, right over the center of the red.
And a little snap one.
Okay, so what you want to tell your patients is typically, you're going to feel a little squirt of cold air against your skin, right? You see, it is a dusky color. It has also quite a wheel around it that appears to be from the cold. So you have a relatively good color, but you can go higher. Let's recalibrate and let's go through every 0.5 joules so that you guys see what happens when
We're going to stand by again to
when
change
you
it.
are right.
14.5 joules, 1.5 milliseconds, spot size still 3 milliseconds.
Very good. All right. Next, bubble. Goggles on, please.
Goggles. How's that one? Alright, you're gonna feel a snap and some cold. 1, 2.
Okay, how's the color? More dusky?
A little bit, but
A
not,
little bit.
not too much different.
Okay, Holly, you dial it up the next level over.
Okay.
On
Well,
the side.
why don't you leave it right now and not kind of go back, forth. We want to get through that in a little
I'm
bit
not
of
going to
speed.
delay anybody.
Okay. All right, Holly, are you ready?
I'm ready.
Have you already recalibrated the laser? He doesn't do anything before you calibrate him. You can. Okay, I can show you. Try it. You feel like, oh, I just upped it, but you can actually not operate. Try on both. Try to see if you can actually operate, and hold on the next possible over. So I think this one, did we treat this one or?
Yes, we treated these two.
Okay, good. Go ahead.
1, 2, 3. But nothing's gonna happen, and
Yeah, doesn't work, right? Yeah, he is cranky. He does not do anything until you tell him, get that energy to where it needs to be. So how do you, very good. Okay, very good.
Alright. Perfect. Okay, now for the real deal. Alright. Snap.
Very good. All right, next one over.
There is a
We're gonna-
camera. Camera wants to look.
Oh, the camera wants to look. The camera looked at this one was treated. Okay, next energy over. I'm just running through an exercise so that you guys get familiar with what you're doing. He needs to be inserted so the portal can read. We might have to, not that the metal is really conducive, but it's just gonna happen. All right, let's get to your angioma, and let's see what happens with 16.
Just the goggles on it.
Well, can you put some goggles on, please? We want to be quick with our energy delivery, and in these cherry angiomas, we also want to be quick. And so there's always a little bit of a variation, whereas in those very large vessels that are sitting on the sides of the nose here, we want to have that slow cook. Can there be somebody who has good results when you do a quick snap? Yes, but sometimes if you have a lot of blood at once that gets excited, then you have to also understand what ramifications there are for cosmesis. Every pulsed dye laser has the ability to cause trouble. If you were to treat something on the tip of the nose and there's a little swelling underneath, you see here, for example, there's a little swelling underneath every single one of them. Sometimes that swelling stays for a few hours. When you have that swelling on the tip of the nose and somebody brushes against the pillow in the middle of the night, and that's the night after the procedure, they might actually create a dimple here. And if you didn't see that beforehand, that they need to cover that area with a Band-Aid before they go to sleep, then they're going to come back to you and say, Holly, you just caused this most terrible scar in my skin. And what are you going to say? Not good, right? You're going to say, I'm going to call Franziska right away. How did that happen? That was not supposed to happen, right? So there are predictable side effects, and the nose is a delicate area, and while we treat lots of blood vessels on the nose, it's a delicate area, and in fact it is a pulsed dye laser that can also resurrect that tissue. But if you don't have the trust of your patient because you didn't mention anything beforehand, that patient is not going to allow you to put the pulsed dye laser there. Might not even allow me to put the pulsed dye laser there, although I'm going to say, but I know that. And they're going to say, I lost the trust forever. And that is where we're running into difficulties with cosmetic procedures. We want always our patients' trust, and we only gain our patients' trust if we can prepare them for anything beforehand. Now, there are some patients who are going to say, well, my Band-Aid fell off. I accidentally scratched the area. I know I wasn't supposed to do that. But, help me through it. Then they're going to be appreciative that you can get them through this and can actually resurrect that tissue with the pulsed dye laser. Right? And so it's always in the explaining beforehand and never in the trying to fix afterwards. Right? So, overall, what questions, if any, do you currently have for the operation of the pulsed dye laser?
So if you were to treat like a cherry angioma and you needed to go up in the jewels if you weren't getting a good enough response, when would you decide to go up on the jewels versus going down on the poster region?
I think if it's really truly a cherry angioma of that very small size, and we're not talking about a slightly raised cherry angioma that we then call hemangioma, I'm probably going to say by about 21 joule, I feel like I should have already gone to that cherry angioma. I should have already been kind of at the depths of where I wanted to be. So here I'm going to have to narrow my pulse duration.
Okay.
Right? I have never had such scenario, but maybe sometimes if you were to treat something that's called lymphangioma circumscriptum, and you have these kind of scenarios, they are a little deeper, you will have to go a little deeper and only then go narrower. Right?
Is there ever an indication where if you were treating a hemangioma small, that you'd ever double pulse, if you weren't seeing that clinical endpoint?
Mm-hmm.
Okay.
Yes, but there's a difference between double pulse and double stack, right? So double stack means you already know beforehand that you want to deliver double the energy, and you can do that in some rosacea settings, and you stay with your distance gauge right on where you want to be, and then you're going to hit your switch twice. You don't move at all, right? And double pulse is you do one, you look, oh, not good enough, let me go back here, and then you can double pulse. Absolutely. If you haven't gotten to that clinical endpoint that you wanted to get, but you still need to treat that spot, I go over it again. And yes, it's going to be a little duskier than any of the following ones, that's for sure. I mean, ideally you would want to try, if there's another one to try on to see to get your energy settings where you want them to be, and then go back, that will be better, rather than trying on that very singular one. But if you're only treating a singular one, then you have no other place to go to. And then even if you add like a little bit more and go over it again, it's already going to give you a nice tissue response. Right? So a vascular laser is also treating brown. We spoke about that. And there are brown spots that we treat. Now, needless to say, hair is also brown. And so you treat hair away. So if you're treating a port wine stain, and you are anticipating anywhere between, let's say, 12 to 20 sessions to treat that person, not only will you have disclosed that there's going to be a loss of pigment once the port wine stain is gone, but you will also have disclosed that there's not going to be hair. And so if you have a port wine stain that goes into the hairline, if you treat that area, you're going to create nice hair reduction. You can use this for hair reduction. It's not an efficient laser for hair reduction, but you can definitely use it for it, and it will work. And so most people will not treat port wine stains in hair-bearing area. When we have a child that has a port wine stain that goes into the brow area, we shield the brow. We can use a number of different things to shield the brow. I like to use tongue depressor that works. Theoretically, you could use a metal object because we use metal also to shield the eyes. And it's usually that kind of darkened metal that we have that isn't quite as reflective. Where are those goggles? Oh, you have them. Can I just... The intraocular shields, yeah, for that you need to apply anesthesia, right?
I guess tetrapain is what, I mean, hopefully we're not doing that though.
That would be terrible if you guys were doing
Yeah,
that.
no, I did it at Wash LA a lot, and it always would.
The
So I know how to.
intraocular shields?
Yes, I did. Yeah.
And who takes the responsibility if you cause a corneal abrasion?
I know it scared me every time. I hated doing it. I did a lot, but yeah, we'd numb them with that
Tetrapain out of website.
Glue the eye and just place them in there. Yeah. Nothing ever happened, but every time I was like, oh.
But there would have been somebody who took that responsibility for
Yes.
you, I suppose,
Yes.
yes? Okay. Well, I mean, technically, if you know how to do it, right, and if you don't have a fear factor of doing it, like I don't have a fear factor of putting ocular shields, and for
I
me,
have a
it's
fear
I have a caution factor, right? But I don't have a fear of doing it. But you know, I don't mind if anybody wanted to do it. I mean, it's difficult a little bit to defend that an esthetician is doing it, right? Because
Yes,
if
I
there was
totally
ever
agree.
legal action,
Yes.
I think there is a problem. But as a physician assistant, theoretically, you can learn how to do this. It's not difficult. It's just a lot of thought at that very moment when you're putting them in, because you cannot afford to create a corneal abrasion, right? I'm just mentioning, right? So far, the only person in the office, I think everybody is scared of it, and you know, I'm the only person who's doing it. But you see, you have this kind of metal. So if you had anything metal that had this kind of, you know, non-reflective surface, then that's also okay to use over a brow area. Likewise, there might be many patients who are coming to you with little angiomas on the lips. You're gonna say, "Oh, I have that right laser for you." What are you gonna do? Treat or not treat?
I'm gonna talk to you first.
Very
because-
good. That's a good answer. Would you treat or not treat?
I would talk to you first, that's now.
Okay, do you want to know the answer now?
Yes.
Okay, you don't treat. Absolutely not. Why is that? You're going to create a white spot there. There's so many blood vessels. If they are all going to become cranky because you're trying to get that angioma out, you have just created a white spot on the lip. Now that person didn't want a white spot on. He just didn't want the red in the red, but he didn't want the white. And so you cannot treat that area. You're going to say that laser hasn't been developed that will do that for you.
Because the pigment in vermilion will not come back. It's by high itself.
Right? And you had seen the photograph of that vermilion defect
Yes.
on Tuesday, right? And so really, really very important that we obey, you know, certain things. This laser can hyperpigment you when you're using too much cooling. There's a cooling button in here. That's an important button to know. The cooling button is kind of, it's preset at 2. That's what works for most people, skin types 1 through 3. If we are sometimes treating somebody who's more darkly pigmented and we feel that we could maybe get away with a little lesser cooling, then you can regulate and dial this however way you want. So first of all, you can increase the cooling. That will, in a fair-skinned individual, create less of an impact of heat on the surface of the skin, and that might reduce pain a little bit. And then it goes to 0, and here it becomes like, oh my God, warn me, it's off. Right? That is not good. But sometimes when you attach this lens, it will come off because there is no cold that can go through here. So I'm going to show that in a second.
You turn that off for warts?
For warts and for basal cell cancers, we turn it off. I don't turn it off for all warts, but oftentimes yes, because I want to even reach the surface with it. We want to be quick with our energy delivery. And in these cherry angiomas, we also want to be quick. And so there's always a little bit of a variation. Whereas in those very large vessels that are sitting on the sides of the nose here, we want to have that slow cook. Can there be, then you will see that the laser actually turns it off for you automatically. You have no choice. You cannot force cold air through a window. That's just not going to go anywhere. So it's automatically off, and that's a default in the system, right? And as you turn it back into a regular distance gauge, it will automatically reset to these 2 bars that you were accustomed to. Perform deliveries. Okay? Good. Do you feel confident treating your first patient with a cherry angioma?
I do with a cherry angioma.
I do as well.
Okay, rosacea. Rosacea requires 2 different types of settings. There's
So when you're done, just turn it off.
which off button?
Open it off.
This one.
Yeah.
Okay. All right. When you want to treat rosacea, there are 2 different types of settings that are our go-to settings. They are everybody's go-to settings with the pulse dye laser. The settings are usually with a 10 millimeter spot size so that we can deliver, we can kind of,
So when you're done, just turn it off.
which off button?
Open it off.
This one.
Yeah.
Okay. All right. When you want to treat rosacea, there are 2 different types of settings that are our go-to settings. They are everybody's go-to settings with the pulse dye laser. The settings are usually with a 10 millimeter spot size so that we can deliver, we can kind of fastly go over the skin, but also because we want the energy settings that are the right energy settings. So most of the time there's the 10 millimeter spot size. We want to treat at 20 milliseconds to be able to treat the wider and the skinnier ones, the kind of that diffuse, and actually we treat at 10. In this mode, we never treat double pulse, ever. Never treat double stack, for sure not. This is a lot of energy. You see, I'm all the way at the top here. This is a lot of energy for that spot size. You need to understand that with that you cannot really play around. What you can do is that 10 to 20% overlap. So once you're lasering through, you go, 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 and you have nice tissue response. It will ideally not turn somebody purple. This sweating, 20 milliseconds, is not supposed to make somebody purple. There are some people who, despite this, will turn purple. Now you're in your mode, you're going, then you're looking at the upper cheek where you were a minute ago and you're going to say, oh! You have to tell the patient. Ideally, you have to tell the patient before. Most people do not bruise with this, but this can happen every once in a while. And when you're starting on the outside, you at least have that on the side there, and then you can readjust and you can go back to your settings, and you might think, oh, maybe that's not the right setting for them. The other
So when you're done, just turn it off.
which off button?
Open it off.
This one.
Yeah.
Okay. All right. When you want to treat rosacea, there are 2 different types of settings that are our go-to settings. They are everybody's go-to settings with the pulse dye laser. The settings are usually with a 10 millimeter spot size so that we can deliver, we can kind of fastly go over the skin, but also because we want the energy settings that are the right energy settings. So most of the time there's the 10 millimeter spot size. We want to treat at 20 milliseconds to be able to treat the wider and the skinnier ones, the kind of that diffuse, and actually we treat at 10. In this mode, we never treat double pulse, ever. Never treat double stack, for sure not. This is a lot of energy. You see, I'm all the way at the top here. This is a lot of energy for that spot size. You need to understand that with that you cannot really play around. What you can do is that 10 to 20% overlap. So once you're lasering through, you go, 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 and you have nice tissue response. It will ideally not turn somebody purple. This sweating, 20 milliseconds, is not supposed to make somebody purple. There are some people who, despite this, will turn purple. Now you're in your mode, you're going, then you're looking at the upper cheek where you were a minute ago, and you're going to say, oh, you have to tell the patient. Ideally, you have to tell the patient before. Most people do not bruise with this, but this can happen every once in a while. And when you're starting on the outside, you at least have that on the side there, and then you can readjust. You can go back to your settings, and you might think, oh, maybe that's not the right setting for them. The other settings that we use for the treatment of rosacea is at 6 milliseconds and 7 joule at that same 10 millimeter spot size. This is a very, very common setting to either, we can use this at 6 milliseconds or at 10 milliseconds, and we can double stack. So if you have somebody with a stubborn rosacea, you did your first treatment, let's say you chose these types of settings because the patient had more visible blood vessels than that background erythema. You see the patient back, okay, looks a little better, maybe not all that great yet. Let me see if the patient can tolerate a double stack. These go over small areas, see how they're responding to the double stack, and you just do it. But sometimes it's just a matter of waiting enough, taking that deep breather, and allowing to see that end result. And it's not visible always at 1 second right after. You sometimes have to wait 30 to 60 seconds.
That was my next question. For just an example, like stacking when we were doing thinning, we would, the second stack would do the whole face, and then we'd come back, so we wouldn't do one section and then go back, we would complete 3 and then move on.
But you're talking about stacking and not passes.
Right. So didn't really wasn't really clear. It's
An antihistamine is like not the end of the world, and so this is a little bit of something what you can do. But if somebody's eyes are really shut, then it's a little bit of a problem. They cannot see for 3 days, and it's very annoying. And then they want prednisone, and then the ones who don't want medication need the prednisone, and then you're really in trouble. Now you have to explain all sorts of things with the prednisone, and so make sure that your patients sleep elevated at the night after the procedure, preferably with their pillows popping up and on their back, so that it's not that full force of inflammation going all the way forward, right? And so that's kind of an important feature, with many laser procedures, but specifically where you induce so much inflammation. Since the COVID pandemic, we have noticed that there are many people who have extremely irritable vasculature, and these are younger people who come in with horrific swelling after procedure. Why is that? The speculation is because COVID has such an affinity to blood vessels. The blood vessels are a little bit on the crankier side, and since this guy is angering the blood vessels, it leads to more inflammation. And so we've seen a number of what we call unexpected events in people much, much younger. And so I think, and it only happened really since COVID. And then there's one unique thing to this. Every once in a while you have a patient who you treat in the winter time. They might have had a common cold, they didn't tell you, or they didn't even remember, and it was, let's say, within 2 weeks of the procedure, and they come back with very blotchy redness, and you're going to say, oh, what did I do here? I was just going to treat their rosacea, and now I created way more visible redness. It is very difficult to preempt that all the time, and we're not always thinking about it, right? But in the consent form, it says sometimes redness occurs. In fact, you actually treat it with style laser. But you have to now adjust the energy settings. And there's nothing during your procedure that would have prepared you to that. Nothing. It's not like you could have told the patient, oh, by the way, this area is going to look a little bit red for a few weeks. I might have to go over with the style laser one more time in order to make that red go away. There isn't such a thing as really truly preempting, but if we can be good about saying sometimes there can be paradoxical redness, sometimes there can be paradoxical swelling, then we have the patient on our side and we don't have a cranky patient. Can scarring occur with this laser?
Yes.
Although he's a non-scarring laser.
Right. Herbert's nice.
Herbert is nice.
Thank you.
Good.
So I have a question. Why would a person, like for example, I've had hundreds of IPLs at probably at 15, 44 settings.
Mm-hmm.
And even with antihistamines, my eyes swell shut. I mean, every time.
And what's your dose of antihistamine?
Oh, probably not enough, maybe, because I'm sleepy. 2 tablets of Benadryl.
So Benadryl is not one of those stabilizers. Benadryl is excellent for hives, beautiful for hives. But as a stabilizer, we don't use them. So we use Claritin
Okay.
most of the time. I don't like to suggest Zyrtec because in some people it can create a little bit of a drowsiness. So I don't recommend it as frequently. But Loratadine or Claritin, this is my go-to.
Okay.
So I think almost everybody here in the practice will also choose that.
Okay.
Now there are some people who are already on antihistamines, they probably need an extra dose. Like they don't just need to take the 2.
Yeah.
Somebody with seasonal allergies might then take 3 instead, so they take 2 extras. And if they're already taking Zyrtec and they know how to respond to a higher dose of Zyrtec, they can take it. They might have had to take it at a higher dose before, they know, but if they're getting sleepy because of that higher dose of Zyrtec, then maybe they take their regular Zyrtec and in addition they take 2 Claritin. That's doable.
Okay.
If someone had like broken capillaries in addition to this like background redness or rosacea, you treat the broken capillaries first with those settings, and then that same day you can treat the rosacea.
So when you're done, just turn it off.
Which off button?
Turn it off.
This one.
Yeah.
Okay. All right. When you want to treat rosacea, there are 2 different types of settings that are our go-to settings. They are everybody's go-to settings with the pulse dye laser. The settings are usually with a 10 millimeter spot size so that we can kind of fastly go over the skin, but also because we want the energy settings that are the right energy settings. So most of the time there's the 10 millimeter spot size. We want to treat at 20 milliseconds to be able to treat the wider and the skinnier ones, the kind of that diffuse, and actually we treat at 10. In this mode, we never treat double pulse, ever. Never treat double stack, for sure not. This is a lot of energy. See, I'm all the way at the top here. This is a lot of energy for that spot size. You need to understand that with that you cannot really play around. What you can do is that 10 to 20% overlap. So once you're lasering through, you go, 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 and you have nice tissue response. It will ideally not turn somebody purple. This sweating, 20 milliseconds, is not supposed to make somebody purple. There are some people who, despite this, will turn purple. Now you're in your mode, you're going, then you're looking at the upper cheek where you were a minute ago and you're going to say, oh! You have to tell the patient. Ideally, you have to tell the patient before. Most people do not bruise with this, but this can happen every once in a while. And when you're starting on the outside, you at least have that on the side there, and then you can readjust and you can go back to your settings, and you might think, oh, maybe that's not the right setting for them. The other settings that we use for the treatment of rosacea is at 6 milliseconds and 7 joules at that same 10 millimeter spot size. This is a very, very common setting to either, we can use this at 6 milliseconds or at 10 milliseconds, and we can double stack. So if you have somebody with a stubborn rosacea, you did your first treatment, let's say you chose these types of settings because the patient had more visible blood vessels than that background erythema. You see the patient back, okay, looks a little better, maybe not all that great yet. Let me see if the patient can tolerate a double stack. These go over small areas, see how they're responding to the double stack, and we just do it. But sometimes it's just a matter of waiting enough, taking that deep breather, and allowing to see that end result. And it's not visible always at 1 second right after. You sometimes have to wait 30 to 60 seconds.
That was my next question. For just an example, like stacking when we were doing thinning, we would, the second stack would do the whole face, and then we'd come back, so we wouldn't do one section and then go back, we wouldn't complete 3 and then move on.
But you're talking about stacking and not passes.
Right. So wasn't really clear. So instead of, to give time to actually see if there is going to be some clinical endpoint when treating with this. We wouldn't want to, stack in one area, and we want to, just complete the rest of the face and then go back to it. Does that make sense?
Okay, so there's a difference between passes and stacking. Your stacking is you stay and you press your foot better twice or your finger switch. So if you stack, you don't think about doing even an additional pass on that. So if you have a small area, you're basically going to treat about 4, 5, 6 points with 10% overlap. Then you take a small break and you look. That's what you do when you stack it, right? Because you don't know yet how the patient is going to respond to that. So you're not going to complete a full cheek, although you might be speedy enough to do that. But what if you're so fast that you're missing out on it? That is the problem.
Yeah.
And when you have a device where it caused with your pulse dye laser, you actually create collagen. And this is also one thing. You don't just inhibit the blood vessels, you actually upregulate the collagen. And so that tissue comes up and that scar has not been created. And you've just worked a miracle for your patients.
What if that scar, I had a patient today, she had an atrophic scar right in between her brows that was from childhood. She had a laceration. It wasn't due to acne or anything. But it was hypopigmented. However, it was obviously pressed. And what settings would you use if there was
You cannot
no,
treat it with that.
Okay.
There's no point.
Pigment.
There's no vasculature that you're even targeting, and you cannot hope for this to create so much tissue recovery that it will be in skin level. That is not that kind of laser to do that. You need to create a hypertrophic scar within an atrophic scar in order.
So when you're done, just turn it off.
Switch off button. You probably, I don't know if you saw you were not here last week, right? Like in the esthetician session, a week and a half ago. The one with the acne scars on the back that we were trying to pull the.
Oh, was it my patient, Jesse?
No.
No, not him. Oh.
I had presented a patient, but I'm not sure if you were in the session.
Okay.
It was 10 days ago.
I've only been here for about 10 days total, so.
I know, and I think that was the week where your cat there was an issue with the cat.
Oh, yes. Oh, that was. Then I know exactly what day that was. Yes. Yeah, I wasn't there for that.
So this one is not just inducing collagen. We don't use him to induce collagen, except when we just created that dimple that somebody with the kind of scratched off. Right.
If you're doing obviously running it by you first, someone that's skin type 4 and you want to do a test spot on them first. This is probably a dumb question, but you're doing a test spot and then you're just waiting that minute, seeing how the skin reacts, and then potentially going through a treatment that day, or would you have them come back and...
There are a number of options, right? So if you are trying to see how their pigment reacts altogether, if they're going to really hyperpigment or hypopigment, depending what you do that test spot and bring the person back at 3 weeks. At 3 weeks, you should be able to see what you have done with the pigment.
Okay.
And you want to take photographs so that you know where did you treat, so that later you can go back and take a look. Is this hyperpigmented or not? Sometimes it's a little bit more subtle. You don't see it as much. Right? So you use your white marker, take another photograph just so that you have everything lined up.
Got it. And then say they did hyperpigment or something, would you potentially try decreasing the cooling if it was okay by you, and then try again?
Again, you don't have to ask me for the test spots. You can even do what I do many times, is I do multiple test spots. I do this test spot with this, do this test spot with this, and I do this test spot with this. Of course, I write myself a note as to where what is, and then I will see the next time, and I will say, okay, I'm in the safe with all of those settings, so it doesn't really matter what I use. Or I'm not safe with this one, so I'm going to stay away. So when I treated this patient with skin type 5 and the large port wine stain on his cheek, I used the side of his cheek to get those settings, to have an understanding. How can I treat him with the pulse dye laser and still create something that's safe? Of course, am I going to see that the port wine stain is gone? No, that's not what I'm looking for. I'm looking for all sorts of other nightmare around that.
That makes sense.
Okay?
Are there any skin types that, besides like ultimate like dark 6 or dark 5, that you just would not risk? I mean, if it wasn't a port wine stain, it was just hyperpigmentation, like that you would.
Dark laser is not for hyperpigmentation
Well-
of anybody who is skin type 5 or 6.
Yeah.
This laser is, in general, not for somebody who's skin type 5 or 6. Does that mean that we never use it? No, there are keloids that we treat with this because the keloids are already darkly pigmented. Somebody might be skin type 6, I still treat that person. And you guys too, right? So there's never a never, but for anything that's not already a scar or a keloid, or let's say there isn't going to be a scenario where you're going to have to treat somebody who's skin type 5 with this laser. Why is that? Because if anybody legal came around, they would say, and still create something that's safe. Of course, am I going to see that the port wine stain is gone? No, that's not what I'm looking for. I'm looking for all sorts of other nightmare around that.
That makes sense.
Okay?
What else I have?
Are there any skin types that, besides like ultimate like dark 6 or dark 5, that you just would not risk? I mean, if it wasn't a port wine stain, it was just hyperpigmentation, like that you would.
Dark laser is not for hyperpigmentation
Well-
of anybody who is skin type 5 or 6.
Yeah.
This laser is, in general, not for somebody who's skin type 5 or 6. Does that mean that we never use it? No, there are keloids that we treat with this because the keloids are already darkly pigmented. Somebody might be skin type 6, I still treat that person. And you guys too, right? So there's never a never, but for anything that's not already a scar or a keloid, or let's say there isn't going to be a scenario where you and still create something that's safe. Of course, am I going to see that the port wine stain is gone? No, that's not what I'm looking for. I'm looking for all sorts of other nightmare around that.
That makes sense.
Okay?
What else I have?
Are there any skin types that, besides like ultimate like dark 6 or dark?
Because it was, not because, let's say, Dr. Gonzalez treated, but there's not a doctor title in front. And automatically comes this, maybe I'd seek legal advice. Unfortunately, you have to be very careful with all of those kind of scenarios. Unfortunately.
Another question. So rosacea, obviously, usually I think it's like 4 to 6 treatments spaced 4 to 6 weeks apart.
I say 3 to 5, and I don't charge after 5. I don't tell the patient that up front,
Okay.
but I say that rosacea is very, very important that you know how to communicate how rosacea responds. It does not respond this way. There's no linear response in rosacea. There are some people who see barely anything after 1, if at all, hardly anything after 2, by about 3, starting, and then all of a sudden they're getting great results. These are the people who are going to have results for a long period of time, typically 7 to 10 years. You can treat about 4 or 5 times, you have great results, you have just made it happen. The worst is, person comes back and says, my rosacea is almost gone. Then you're going to have to say, okay, let's not treat. You're not just going to treat into nothing. You're going to have to say, unfortunately, most likely your witness is going to come back within a year, and you're probably going to come see us once a year. Unfortunately, you did not enter that phase where I can deliver these many treatments. That's unpredictable in redness, right? But rosacea is a moving target. Everything red is a moving target. If your patients are not committed to the time frame, to the intervals for the face every 3 to 4 weeks, for anywhere off the face, except sometimes poikiloderma on the neck can also be every 4 weeks, but on the body closer to 6 weeks. If they're not committed to coming back, they're saying, oh, let me do one treatment now and then I'm going to come back in the fall, you're going to say, I'd be happy to collect your money, but I'll start over again. Right? So you have to disclose that. You cannot say in the fall, why didn't you come back during the summer? Because now I have to start over again. And now your series of 3 to 5 starts over again. A series of 3 to 5 is not one over the many years, right? So it's really in sequence.
Speaking of summer, do you tend to not treat with this if someone that you know you don't trust them, that they're not going to sun protect?
If I don't trust them to sun protect, I don't treat them, period. I will have to say, you learn how to sun protect, then we can talk laser. Whether that's winter or summer. I don't treat somebody who does not. Typically what will I say? Do you want to throw out your money for nothing? Right? I mean, first I'm going to cause bad side effects. You're going to get funky hyperpigmentation. Then you're going to hate me. And then you definitely are not going to lose this, whatever you're trying to lose. Right? I will paint a bad picture. You can say it much nicer. You can say it would be really unethical of me to treat you. Right? So find whatever you can say that will make the patient understand without providing blame. And that sentence, it would be unethical of me to treat you, removes the blame. Right? It puts blame on you in case you did it. Right? But you signal to the patient, that would be terrible if I laid hands on you. Right? If they are 10, you cannot treat them. If they are 10, and if they have, the worst is always somebody who comes with an excessive tan and has all these freckles everywhere, and then they see one larger lentigo and want that off. What do I say? Yeah, I can maybe remove it, but I'm going to create a white colored spot. Take a look how the breast looks. Take a look how the buttock looks. This is the skin color that I'm going to reveal there. Would you like that? I'm not ready to give that to you because I don't believe that that is really what you are looking for. So you're going to say, I can treat this. If you want me to, come back in the winter time. Come back 4 weeks after your most recent sun exposure. And we're going to take everything off. That leftover permatan and the freckles, and it's going to be a project, but you're going to look like a movie star in a year.
Do you ever have patients who come in with self-tanner?
You can't treat them because there's a particulate amount, and so here, this guy sees brown and still creates something that's safe. Of course, am I going to see that the port wine stain is gone? No, that's not what I'm looking for. I'm looking for all sorts of other nightmare around that. That makes sense, okay? What else I have?
Are there any skin types that, besides like ultimate like dark 6 or dark 5, that you just would not risk? I mean, if it wasn't a port wine stain, it was just hyperpigmentation, like that you would.
That laser is not for hyperpigmentation of anybody who is skin type 5 or 6. This laser is, in general, not for somebody who's skin type 5 or 6. Does that mean that we never use it? No, there are keloids that we treat with this because the keloids are already darkly pigmented. Somebody might be skin type 6. I still treat that person. And you guys too, right? So there's never a never, but for anything that's not already a scar or a keloid, or let's say there isn't going to be a scenario where you're going to have to treat somebody who's skin type 5 with this laser. Why is that? Because if anybody legal came around, they would say, are you crazy? Right? It's a no-fly. What a yag. That burns deep holes. I don't know if I can show you